Good morning, everyone. We just wait for everyone to join now. Just take a few seconds and then we'll start going through the introduction of the webinar. Fantastic to have you all here. It's a good opportunity for you to learn to use the Q&A or the chat if you haven't done that already. We love to know whose country you're on. I'm in Nam, in the land of the Wurundjeri people. If you know where you are, love us to hear where you are on the chat, and we'll just give people a few more seconds to join and then we'll get started. I think we've got about half of the people online. I know sometimes people turn up a few minutes late, so we won't wait too long. Okay, I reckon that we'll make a bit of a start. Thank you. So as people are putting in their wherever they're from, thanks, Shaim. I was over your way just yesterday. I'd like to acknowledge the traditional custodians of the lands on which we're all living and working today, and the continuing connection to land, water and seas. I'm on the lands of the Wurundjeri people of the Eastern Kulin Nation, and I'd like to pay my respects to their elders past, present and yet to come, and also acknowledge any Aboriginal or Torres Strait Islander people who are with us today on this webinar. You're very welcome, everyone, indeed. So I'm going to just spend a couple of minutes. I'll introduce the amazing Mark Cormack in a moment, explain to you the purpose of our consultation today, and then really pass over to Mark, who's going to give us a whistle-stop tour of everything that's been happening at pace in the last few months in relation to the scope of practice review. And then at the end of that, we'll have a Q&A session. So what we encourage you to do is, as you're listening to Mark, or even now if you've got a burning question, to pop them into the Q&A. We've only got 20 minutes or so and it goes really quickly. So it's a good idea, if you think of a question, to pop it in. As you know, no such thing as a stupid question. All the questions that you have are really helpful, both to CHF but also to Mark and his team to understand the important issues for you today. Thanks. So my name's Elizabeth Deveny. If you haven't met me before, I'm delighted to be with you today. I'm the Chief Executive of Consumers Health Forum of Australia, and I'm joined today by Professor Mark Cormack, who is the lead reviewer for the Independent Scope of Practice Review. Such an important piece of work. Every day, Mark, we hear from consumers talking about issues with accessing care, and this scope of practice review is clearly a very important piece in helping to unlock some of those access blocks. Professor Cormack works at the Australian National College of Health and Medicine and also established ANU's a National Centre for Health Workforce Studies, so he's very well positioned to lead this work. His academic role follows a long career in Commonwealth. Many of you will know him from his work in Commonwealth in jurisdictions, including as CEO of Health Workforce Australia, who we all still miss, as CEO of ACT Health and the Deputy Secretary in various Australian government departments, and that's certainly when I first met him many years ago. So, Mark, if you're happy, I'll just quickly explain the purpose of the of today, and then I'll let you go ahead with your session. So, as I said, we hear from consumers regularly about issues with access. What we hear really strongly from consumers, pretty much every time we interview them or talk to them about an issue, is they're not too concerned about which profession gives them a service, as long as that person is appropriately qualified and can deliver it safely. Yep. So if we talk about prescribing, which has, had a lot of airplay in the last year or two, whether it's a pharmacist, a nurse practitioner, a GP, what people want to know is that they can get care and that care is affordable and safe and high quality. So the perspective of consumers about scope of practice, how it impacts on their daily lives and their ability to access affordable healthcare is hopefully what you'll get today through both the questions that come in the chat at the end, but also our contributions to the survey and our roundtable held later this month. So this webinar will really give you some background to better understand, well, what is the scope of that review, what's in, what's out, and what are the team doing, and help you, if you're intending to be part of our roundtable later this month, help you understand what some of the key issues are. We also encourage everyone here to complete the online public survey that the department has. We've got the link on one of the later slides, and we'll send that out later if you don't have it. And also, if you're interested in being part of our roundtable, you can also join that, and we've got the information about that at the end of this presentation. So I'd like now to pass across to Mark, and we'll leave us in your capable hands. Thanks, Mark.
Great, thanks very much, Elizabeth, and thank you very much for the opportunity to have this session with you today, and we're really looking forward to our roundtable with you on the 26th. And just keep it front of mind, what we talk about today will help, I guess, in many ways shape the way we run that forum to meet your specific interests and requirements. So, yeah, look, first up, what is scope of practice? I guess some working definitions here. It really covers the full spectrum of roles, functions, responsibilities, and activities and decision-making capacities of an individual within a primary healthcare profession. The activities are what the individual is educated, competent, authorised, either through formal national regulatory arrangements or through adherence to self-regulated professional standards, and that they are accountable to perform. And some of these activities may be shared with other professions, groups and individuals, and the context of multidisciplinary teams is very, very important here. So the review is about identifying opportunities to remove these barriers that are stopping health professionals working optimally to their full scope of practice. And as I mentioned, also very much on multidisciplinary care teams. The two are very closely interlinked. Can I have the next slide, please? The background to the review is the Strengthening Medicare Taskforce. It was completed in December 22. National Cabinet endorsed the Taskforce recommendations in April of 23, and the scope of practice review was announced and funded in the 23-24 Commonwealth budget, along with a number of other measures responding to the Strengthening Medicare Taskforce Report. Next slide, thanks. So just to refresh, I know that you're all very familiar with the Strengthening Medicare Taskforce Report, but there are essentially four major kind of areas of recommendation and focus coming out of that report. Firstly, our system should increase access to primary care through equitable, affordable, person-centred primary care services that are easy to navigate. Secondly, that our system should encourage multidisciplinary team-based care, where health professionals work to their full scope of practice to deliver quality person-centred care. Thirdly, it's about modernising the delivery systems through data and digital technology, which safely shares information about patients and empowers people to participate more fulsomely in their own care. And finally, and this review in many ways is very much focused on that, supporting change management and cultural change, including empowering consumers and also driving innovation. Next slide, thanks. So the journey to date. The review started in September last year. Its conclusion date is October this year. We've broken it up into 4 phases. We're now in phase 2, and phase 2 essentially focuses on the issues paper, and I'll take you through that in some detail in a minute, which pulls together the themes, the evidence from the literature, and also the very significant input we had in the first round of consultation. We had over 700 submissions. We had a lot of consultation sessions, and I'd just like to commend Elizabeth and the team and all the participation we've had from the Consumers Health Forum to date, and really looking forward to this next phase. Next slide, thanks. So the purpose of issues paper number 1, provide an overview of what we've collected to date, draw those together into emerging themes that we want to test and get reaction to and get some input on, and then kind of describe the direction and next steps for the review. The data collection has been quite significant. There's a literature and evidence review that is underway in the background and is well progressed. Lots of submissions and lots of consultation input. So that's our method. Next slide, thanks. I guess we've kind of distilled down 5 key findings and presented those in issues paper number 1. The first one is that enabling health professionals to work to their full scope of practice supports a stronger primary healthcare system. Equally strong in terms of a finding is that there's a whole range of barriers that are actually preventing that from happening. We, in the bottom of this slide, we identify the 3 major benefits that should follow from health professionals working to their full scope of practice. Firstly, improving consumer access to care, the experience of that care, and also the health outcomes of that care. Secondly, a well-functioning primary healthcare system with health professionals working in multidisciplinary teams at their full scope of practice reduces the workload for the acute hospital care sector and keeps more of us out of hospital in the first place. And finally, working at full scope of practice increases the utilisation of our scarce, highly skilled, highly regulated health professional workforce, makes them more interested in sticking around because their skills are being fully utilised as opposed to being partially utilised. And it also creates efficiencies at a system level. Next slide, thanks. There are 5 emerging themes grouped in the issues paper, and we'll just go to the next slide. And I'll just step you through those one by one. So the first one is legislation and regulation, and obviously these are key levers for scope of practice. We certainly are aware of there are some inconsistent approaches to regulation across health professions. We see in lots of acts that have very little to do with the regulation of health professions, this mentioning of named professions as being the only people who can perform certain functions in a whole range of acts, mainly state and territory government acts. And also within the national regulation scheme for health professionals, there are some delays in progressing recognition of additional skills and endorsements, such as prescribing, vaccination, those sorts of things. So in the issues paper, we identify, and this is basically the structure for each theme, we identify 4 key enablers. The first one is to harmonise drugs and poisons legislation. And as Elizabeth mentioned in her opening remarks, progressing consistently prescribing by all health professionals in a consistent way. It's not only been going on for a couple of years, it's been going on for more than 10 years now in this country. And we still have a very significant inconsistencies. Secondly, within the national regulation arrangements for health professions, which their focus is on regulating based on protecting the title of professions. That is, if you are a nurse, a registered nurse, that means something and certain standards go with that title, and that's very important. But it's also important to recognise that a number of functions performed by doctors, nurses, physiotherapists and pharmacists are common. And it's important that the regulation arrangements focus on the activity that is being performed as much as it does on the the named profession that's performing it. So that's an area we're wanting to have a close look at. Endorsement processes, and what I mean here are that particularly for the non-medical professions, as their scope of practice evolves, for example, to undertake more detailed procedures to prescribe, there requires under the national arrangements an endorsement process, and that basically says that this person has been trained to a certain level through an appropriate training program. They've demonstrated their competence. They keep themselves up to date each year. So the processes for expanding scope are fairly time consuming, and they're not necessarily consistent across professions. And of course, we have 16 nationally regulated health professions, but there's that number again almost of self-regulated professions who aren't part of the national regulatory scheme: social workers, speech pathologists, nutritionists, exercise physiologists, all of those, for example. So we need to bear in mind that the legislation arrangements need to take into account how their standards are monitored. We'll just go to the next slide, please. The second area that we're focusing on are employer practices and settings. And these are very, very important because custom and practice at the clinic level or at the employer level can have a very significant impact on what a health professional is able to do in their employment setting. And by that I mean, you might have, for example, a nurse practitioner or a midwife who is regulated at the national level to perform a whole range of functions. Their training has been fully accredited. Their competence has been assessed. And so they're allowed, in a legal sense, to practice a range of tasks. When those nurse practitioners or midwives present to work in different employment environments, there can be additional restrictions imposed at the employer level above and beyond what they're allowed to do nationally. So in other words, they may have a more restricted scope of practice due to what the employer determines they're able to do. So that can have a very significant impact on the care that consumers receive in their local area, because the employer may be overly cautious, or they may be unaware of what a nurse practitioner or a pharmacist or a psychologist is actually regulated and enabled to do through the national regulatory arrangements. So it's really important that we look at boosting understanding and recognition of what the 16 professions are regulated to do, strengthening multidisciplinary models to enable that to happen, and also to look at the kind of local clinical governance and quality and safety mechanisms that support those practices. So that's employer practices are a very, very important part of the equation. Next slide, thanks. Education and training. It's part of the national regulatory arrangement for 16 health professions, and also there's a parallel system for the non-regulated professions. In the primary healthcare setting, there's a proliferation of education and training requirements across health professions, and they differ very much depending upon how that health profession is regulated. And we have certainly identified through consultation findings that access to professional development training is not necessarily consistently supported, and training requirements for similar or common competencies apply inconsistently across professions. So what's an example of that? There are a number of professions that are trained and competent and regulated to be able to undertake a mental health assessment. And that may be at a different level depending upon the nature of the consumer's presenting needs. But the approach to regulating and specifying the training requirements for a health professional to make that particular initial mental health assessment varies significantly across doctors, nurses, occupational therapists, psychologists, etc. So starting to focus on a common and consistent approach to training and regulation. Also recognising that if we want people and health professionals to work as part of multidisciplinary teams, then the training right to the very beginning of when they enter university for their professional entry programs, that they have a nationally consistent approach to interprofessional competencies. And when they finish their training and are registered and practicing, that they continue to undertake training with other health professionals. So it's not that you, if you graduate as a nurse, that all your training after graduation is only provided by nurses. It really should be within that team context. So there's a lot of work to be undertaken there, and within the issues paper, we identify a number of different approaches to doing that. Next slide, thanks. The fourth area relates to funding policy, and the basic premise here is that you get what you pay for. If your payment system is built on high volume throughput in a traditional face-to-face context, then that's the care delivery that is most likely to occur. We identify some of the strengths and weaknesses of fee-for-service funding. Some of the strengths are that it supports a lot of service delivery and can reward providers for getting through a lot of work. But some of the downsides are that, particularly for patients with lifelong, complex, chronic healthcare conditions, certainly they need lots of episodes of care, but their focus is, through their needs, are very much around planning their care, coordinating their care, guiding and assisting their journey across the complexities of the healthcare system, and often on a lifelong basis. And fee-for-service doesn't really fund that activity particularly well. And secondly, the current fee-for-service arrangements don't really provide the same access to multidisciplinary care that is needed. The Medicare system is very strongly focused on access to medical care, which is great. That's what it was set up to do. But as time has evolved over the 40 years of Medicare, the need to access other health professions and other health workers to meet your needs beyond what a GP can do or a medical specialist can do is becoming a very important part of our system. Fee-for-service doesn't really sort of focus on that. So again, if you look at the potential enablers there on the left-hand side, we look at greater use of block funding, blended funding, payment types that actually incentivize health professionals to work as part of teams, reducing the necessity for all referrals to go back through a GP. So, for example, if a physiotherapist is working on your knee, recommends an orthopedic consult and some imaging for that knee, in those circumstances, we would basically speculate that you don't necessarily need to go back to a GP to get those referrals and then go back to the physiotherapist. We can streamline some of those. And also the final one there is funding episodes of care, identical episodes of care that may be delivered by different professions. And again, immunisation is a very good example of that. So funding policy is a really important part of our consultation round. And the final area on the next slide relates to technology and in particular robust digital health infrastructure fully implemented may enable consumers and health professionals to access and share information safely, work together more collaboratively, save time, and also improve real-time communication between the treating team, particularly if they're not all located in the same place. And certainly in the primary healthcare setting, most people need to go to multiple different locations to get their full care. So the technology options are really to focus on all members of the profession of the healthcare team with appropriate patient consents being able to get access to real-time patient information, and also a focus on platforms that enable contemporary secure messaging and referrals through a digital arrangement. So this is an important enabler. I might just go to the next slide, Elizabeth, and then we might just pause for some questions. So throughout this process of consultation and using issues paper number 1 as the means for doing that, we've been exploring each of those 5 areas that I just described. But as we've certainly found, none of these individual 5 areas can be looked at in isolation. For example, you can make changes in the technology space or in the legislation space, but it has knock-on effects across all 5 areas. So our focus is on the authorising environment, which is what are health professionals enabled to do, mechanisms to strengthen multidisciplinary care teamwork, and also the leadership and culture and governance of our system that's able to support multidisciplinary care delivered by health professionals working at their full scope of practice. Next slide, thanks. So I might just pause at that point. There's a lot to take in there, and we're really keen to use this just as an initial kind of taster and to get some guidance and feedback from the CHF and your members about what the next steps would be for us to have a deeper conversation with you about these. What are the points that are most important and critical? And the other one for me is, have I missed anything that's important to you? So back to you, Elizabeth. Thank you for listening.
Thank you so much, Mark. That was really terrific too. As you said, there's a lot in everything you're doing, a lot of questions you're trying to answer. It's a big gig, right? We've got some questions that people have asked in advance of the session, because that's one of the things we do when people register. We ask them, have you got a question? So now I'm encouraging everyone who's on the call with us today to pop their questions into the question and answer area. I'm going to start with a couple of the ones we've got already while people get typing away. So the first question was really to understand who was in and out of scope, and you did talk a little bit about that, to be very clear on who was in and out of scope, and particularly what about for people like peer workers, for example, where do they sit in all of this? So perhaps you just want to recap on that. And then as you do that, the kind of the corollary, I suppose, is can others be added in at any point in this review, or is it kind of it's finished for now, this is our scope? That would have to be a second piece of work.
Okay, thanks. In relation to the first question, it's pretty broad. So the main there's 2 elements of scope. The first one is the setting, and the focus has been primary healthcare. That's obviously to do with the Strengthening Medicare Taskforce, but that of course does take us into the interface areas with the hospital system and aged care, etc. But it's very much primary healthcare focused. Pretty much all workers who operate within that system are in scope. So it's the nationally regulated professions, it's a self-regulated, it's the assistance and care workforce. The only exception to scope, and it was one that was really set for us before we started, was dental is out of scope. But my response to that is whatever the findings are from this piece of work, and whichever recommendations are ultimately considered by governments, we think there's general applicability. And the second question is, what about the rest of the out of scope areas, which is hospitals? I think ultimately that's a matter for ministers to determine whether they want us to have a look at that as well. But I think there's ample scope for us to make some useful recommendations that will also have general applicability to other areas.
Great. So we know what the scope is for this one, which really does focus on primary care. And, you're leaving the door open for the minister to decide that now we need a second look at the broader environment in the future. So wait to see. We hope you do a really good job. And the minister's so thrilled by what you've done that definitely wants a lot more, because people will talk about the fact that if they have, say, a chronic disease, their journey is not limited to primary care. And people, as you know, with significant disease are often seeing specialists as often as they are seeing their primary care team.
Absolutely.
So making sure that all joins up across would be really terrific. So the second question I have for you, Mark, is about how we will review areas of overlap between health providers. So how are you going to actually look at where the overlap is and make it clearer to the community, I suppose, about where they can go for a service?
What a great question. Thank you for that one. So in looking across both that legislation and regulation area and the education and training area, it's pretty obvious that the notion of scope being exclusively owned by the 16 nationally regulated professions is not, it doesn't really hold up. There are areas of common competency. And let's use an example of, cultural awareness and cultural safety. That is a common competency. Everybody should own that to the same degree and have the same degree of competence in that area. And then there will be areas of overlap, and prescribing is a fabulous example. And just using that as an example, prescribing in its own right is a task and a competency, but then it must be applied to the relevant scope. So, for example, if you're a nurse practitioner working in the diabetes area, it is logical that your prescribing kind of competency should be linked to your scope. You could also have a pharmacist, and increasingly we've got that working in other areas to do with urinary tract infections, etc. So that common competency of prescribing must be relevant and applied to the scope of being a pharmacist working in that area. So I think we need to start to unpack the competencies across the 16 professions, identify those that are unique to the scope of that profession, but also those that apply across professions. The example I gave earlier, I think I gave earlier about mental health assessments, we know that there are a number of different professional groups that make initial assessments of people with mental illness. And the state and territory mental health acts also recognise that. So I think we need to start with what are the competencies that are required to meet patient and consumer needs first, and then as a complement to that, look at which professions are able to deliver that safely. And of course, part of this, Elizabeth, is a much greater public awareness of this complex system, because the one thing that's become very apparent to us is that even amongst the most technically focused and experienced experts in the healthcare system, there is a significant degree of misunderstanding about what each individual health professional group is able to deliver to patients. And that's an area of what would be benefit to the workforce, but also I think of greater benefit to consumers. So there's a very clear common understanding of who's able to do what.
Yeah, thanks, Mark. I think this is a really important point for consumers. So you used pharmacists and enhanced prescribing rights, for example, and we hear from consumers that they don't know which pharmacy can do what, and also how do they trust that. And the one I actually thought about as you were speaking was vaccination, and how during COVID we suddenly allowed a whole lot of new people to do vaccination, many of whom already had the skill of how to give an injection, but traditionally didn't do that. And then for consumers, it was a question of, is it safe to go to my pharmacist? Is it safe that this person will do this for me? How do I know who's allowed to do this and who's not? So you're right, as it is complex, so the need for health literacy for consumers to understand it, but then really strong communications from government and professional groups as so that consumers understand who is okay to do what, because otherwise people either might not get a service or indeed might get a service that perhaps would be better that they hadn't had.
Yeah.
Then there is a little bit of a question, because you started talking about multidisciplinary teams and scope of practice. And someone's got a question for you, which is, doesn't increasing one make the other less important? Because if scope of practice is increased and more overlap exists, the need for a multidisciplinary team, because now we're not saying you can only do this and you can only do that, might diminish over time. Do you have a view on how the scope of practice review might impact on the need for, or indeed the functioning of, multidisciplinary teams?
Yeah. Okay. Again, that's another really great question. So part of our consultation process took us to the Northern Territory in particular, and that was very, very illuminating. And also yesterday we had two very big sessions with rural and remote professionals and consumer groups. I guess what we take away from that is that when you've got a team working together, those traditional boundaries between what a nurse can do, what a pharmacist can do, what a doctor can do, what a social worker can do disappear, because you get this common respect, common understanding, common appreciation of what members of the team can do. So you get kind of like this force multiplier effect, where and it's most pronounced in Aboriginal community-controlled health organisations, where the model is holistic, integrated teams. Who actually delivers your care is less important than the kind of multidisciplinary team model that actually underpins the philosophy and the cultural milieu of that service model. So in that sense, better teams supports fuller scope because you've got greater visibility. The point that you raised, though, which is a good one, and that is, if a health professional is able to do a broader range of activities or a deeper range of activities, does that diminish the need for other team-based care? The short answer is yes. In some instances, it can. But using the example before of a person with chronic and complex condition, even like a nurse practitioner or a pharmacist or a general practitioner working to their full scope of practice is still going to need a strong multidisciplinary team to support the things that they can't do. So it's not either or, but the interaction between the two is really important. And that's one of the best questions we've had in the last 5 weeks of intense public consultation. And I'm going to make sure my team help me to kind of construct that answer a little bit better than I just have then, because we haven't been asked it that way before. And thanks to the person who did so.
It's okay. As you know, the community will always keep you on your toes, Mark. So there's a related question. You started talking about rural and remote. And so, yes, if you've got a fantastic arch like a Congress in Alice Springs, right, with a few hundred staff and lots of different opportunities for team-based care, as you said, increasing the scope can change the way that the team works. What about in rural areas where there are very few health practitioners? So then, of course, the scope becomes more important, but also the capacity to have a face-to-face team, in some cases even a virtual multidisciplinary team, is really difficult. So how are you taking those different geographic contexts into your work?
Look, really, again, good question. Place is everything with this stuff. And we started off our consultations in Canberra, arguably the least rural jurisdiction in the country, and finished it in the most in Western Australia and NT, which are the least kind of urbanised in that sense in terms of the rural remote side of things. So it's clearly a very different approach that's required. And I think the learnings we take away with respect to your question is that in really, really remote places, you need highly skilled super generalists with a broad and a deep scope of practice, backed up by a range of remote supports. Those remote supports, of course, the more traditional kind of telemedicine, telehealth approaches, digital and virtual options, but also one of the things that became very apparent from our consultations was that those workers need supports themselves from specialist colleagues when they get into areas of practice that are clearly they're unable to service. And we've certainly identified in our consultations to date that providing a funding mechanism as well as a kind of a business and service model that enables those very isolated, highly skilled, highly generalist, deep scope practitioners to be able to have the supports they need from people with very specialised skills that are never going to be able to physically appear in the environments in which they're delivering care is probably as important. So I think it varies from context to context. For the extremely remote operator, I think increasingly we're going to have to rely on better use of technologies, more consistent and more reliable use of technologies, but also funding and regulation and education settings that actually support those service delivery models.
Thanks, Mark. I'm just going to continue on this theme of multidisciplinary teams while we're at it, because there are a couple of other related questions. We move to some other topics. But I think one of the last ones is, and I spoke to you about this last year when we met to first discuss the review, regulated and non-regulated professions. But what about people who are carers, peers, and consumers themselves, and their roles that they can play in their health? How that overlap is also understood, and often the lived experience of a person says, I actually can do this, or sometimes maybe even something that perhaps another could do, actually this is not a healthcare activity that I can engage in something support with it.
Yep. Okay, just on a technical sense, I was getting a lot of echoing on that line there, but I think I've got the gist of the question. I think you've probably identified an area, Elizabeth, where we've not had the amount of input and the perspective that we need to be able to kind of make some sensible recommendations about how that, although the two workforces that you refer to there, which I think is the sort of peer plus the assistant workforce, but also that the workforce that the individual consumer brings to the task themselves. We haven't really explored that enough, and maybe that's an area in our targeted consultations with you that we can draw out a little bit more. We've got some additional targeted consultations with a number of different professional groups. The sort of assistance workforce is an area that we didn't give much attention to in the issues paper #1. We certainly haven't had the same volume of input in this phase. So that's probably a second area of gap that we'd like to see if we can work a bit more closely with you, but also with some of the other groups that you interact with that might be able to fill in the blanks a little bit more. But because increasingly those workforces are growing, both not only in numbers but also in importance. While recognising the enormous contributions that they can make and have to make because of, in many cases, scarcity in other areas, we need to ensure that the regulatory arrangements, the training arrangements, and indeed the payment arrangements for those workforces are up to the task. And I think, as I've heard yourself and others say, you care less about the title of the person delivering the care, but you do care most that they're actually safe, trained, regulated, and accountable for the care that they deliver. So we certainly need to do a bit more work in that area, and we'll do so with you over the coming weeks and months.
Great. And I'm sorry for the echo. I'm trying to problem solve that at this end. It's a mystery to me. So we've been talking about the changes to scope, and then of course the corollaries, particularly in primary care, is the MBS, Medicare. So will changes to scope of practice mean that providers can bill more activities, particularly bulk bill more activities, so provide free at point of care, because now the scope is increased. Will, I suppose, if you like, the MBS keep up with what your review might suggest, and indeed what government might be willing to support?
Yep. Look, thanks. A good question. This has been a very big part of our consultations to date. So under the funding policy section, we call out a number of the shortcomings of the MBS fee-for-service arrangement, and I went through that earlier. So the weight of representation that we've had to date is very much, and it's almost unanimous, that it's far more, it's going to be far more useful to focus on block funding and blended funding models that give the health system and the health workforce the flexibility to deliver the care that's needed for the patient, as opposed to continuing to add new and different items to the MBS schedule. So I think the first point we'd make is that further expansion of the fee-for-service system needs to be very carefully considered, and evidence would probably suggest that a stronger focus on more flexible blended payment arrangements, even capitation in some cases, might be a better approach. The other side of that is that there are a number of identical services that are delivered. Again, immunisation is a very, very good example. There are others that are able to be delivered by a multiple range of professions, yet the MBS payment arrangements for those differ, even though it's effectively the same care. And if that's not addressed, then what is the incentive for people other than those that are receiving the highest MBS rate to do that? And of course, pharmacy is a very, very good example of that. So while I think it's unlikely we're going to come forward with a whole lot of recommendations about more and more being added to the MBS, that last point is one that I just made about, effectively a common payment for a common activity. There's something to further consider there, but I think our focus is probably looking at other funding models that are able to give the flexibility for the care that the patient needs to be delivered within the funding model, as opposed to the funding model saying, only a dentist can do this or only a doctor can do that.
Great. And I think this one kind of takes us a little further along that line, which is a question, I think it's from Matt, about mode. So is your review also considering mode, and you kind of mentioned that in part in your last answer, that is virtual versus face-to-face versus remotely monitored? Is that, when you think about scope, is that also included? Yay, Deborah, thanks for letting me know. 15 different things, and finally it went away. Is that considered also? Or is it only really the activity rather than the mode within which it's delivered?
No, it's certainly both. And I think the mode is increasingly what we need to focus on, again, particularly for consumers who find it difficult to be able to access a traditional face-to-face mode, irrespective of where they live, but also just some of the options now that are available to deliver high-quality care in competently and safely in a digital or a virtual environment. The review will be agnostic about setting and mode. It's really important that we kind of move our scope discussions, our regulatory discussions to where the system is, not where it was 20 years ago.
Great, thank you. Kate asked a question about the divide between private and publicly funded primary care. So when the work that you're doing really is being driven through the government's review of strengthening Medicare and so on, but we've mentioned that perhaps you look for different funding models in public care and so on. But do you have a sense of how this might then play out in private primary care?
Yes, we've not been. I mean, obviously, we focus a lot on the MBS and the bigger programs, but as you know, the delivery point for those is more private than public anyway. So we certainly are very conscious of other kind of funding sources and other delivery channels, and I guess the obvious one are co-payments. That's a private funding source. So it's very important to take that into account when you talk about payment arrangements. But also the private and not-for-profit system is an important delivery point in the primary healthcare system. In fact, it's the majority delivery point. And we have had a number of discussions with the private health insurers who, there are private health insurance offerings that support primary health care, mainly of a non-medical nature. So our focus will be to ensure that the recommendations cover publicly delivered care, publicly funded care, privately delivered care, and privately funded care. It's the system as a whole that we're looking at.
Great, thanks, Mark. There's a comment here too from Matt in relation to your terms of reference, and in the section under education, training and collaboration, there's not currently a reference to consumer involvement in health professional training programs to make sure that the role of lived experience of patients, clients, carers and the like is also considered in their training, and indeed in them understanding how they will work with the community and individuals. So that's a comment, I think, more than a question, though you might like to comment on the comment.
Yes, yeah, look, a pretty sizable chunk of our consultation effort, and I think a fair bit of our recommendations in the end will focus on the education and training component. Certainly the feedback across all of our face-to-face consultations is the need to make the training much more kind of focused on the patient needs and centered around the patient, the consumer's requirements. So in making recommendations around, for example, common competencies across professions, common approaches to training, we certainly can incorporate a much greater focus on the consumer's role in that space. And as we all know, it's no matter where you turn up to in the public system in particular, the consumer ends up being a contributor to the education and training of the workforce, particularly in the public hospital sector. You are a piece of educational material as much as you are a consumer who's got healthcare needs. That's teaching hospitals are a very good example of that. So I think that's a really good point. And again, we'd like to explore that a little bit further with you, because it's come up. But I think there's probably more than we can kind of analyse and highlight in that space.
Faye also makes a comment about cultural transformation. That comment builds on the last comment about how do we include consumers in the work itself. So it really, if we're talking about changing scope of practice and changing the way that professionals work with communities and with each other, there's also a big piece of cultural reform that would help us achieve the operational reform you're talking about. Will your review be speaking to that aspect of what needs to happen next?
Yeah, it certainly will. And there are a couple of shortcomings in the issues paper. As we've consulted on, it becomes very obvious which areas, people think we could have focused more on. That is an area that is in our initial terms of reference to focus on the cultural change management aspects. And if you go back to the Strengthening Medicare Taskforce, the 4 goals within that, goal number 4 very much gets to that. We didn't really call it out as strongly in retrospect now as we should have in issues paper number 1, but it's certainly come through loud and clear, particularly when you get down to employer practices and regulation. There is a very, very significant cultural aspect to this. You can make the law as effective as you can. You can make the payment mechanisms as definitive as they need to be. But at the end of the day, it's power balances. Who holds the power, who holds the influence, both within and across professions, but also at the service delivery level. And we will make that a much stronger component in our next effort, which is issues paper number 2.
Now, you've done very well on your oral exam so far today. I've got one last question for you,
Okay.
which relates to this cultural change. So let's say we have freed up people to work more effectively to the full scope of their practice. What will it mean for consumers in asking professionals now perhaps to undertake tasks they didn't before? And if we lay over it that kind of complexity of perverse financial or other incentives, there might be a task that someone's now able to do, but either they don't want to do it, they're not confident to do it, it doesn't pay as much as some other task. How do we make sure that the changes that this review might lead to actually materialise in the practice of health professionals to better support Australians in their healthcare?
Yeah, okay, thanks. And that's a really great question. So when I was talking about education and training, not education, training, employer practices, became immediately apparent to us that the level of awareness, and you talked about consumer literacy, I would actually talk about, professional literacy about what scopes of practice all the different professional groups are able to do. So I think the first thing we need to do is recommend a significant awareness piece so that there's a greater understanding across the board about what the capabilities are of the individual professions, and to give consumers the confidence to say, look, I know you're an optometrist, but I think you're recommending I now need to go to somebody else to get a particular prescription. I thought you were certified, or I should say endorsed, to be able to dispense a medication with this consultation. So we hope to be able to kind of give people the confidence to understand what's possible. But the second thing is, whatever changes we recommend, there needs to be the incorporation of some ongoing experience measures, outcome measures, PROMs and PREMs, all those sorts of things that the Consumers Health Forum are very, very much focused on. So we need to incorporate some evaluation mechanisms to determine the impact and the extent of both cultural change and scope of practice change across the system. And again, that's probably something more for our draft final report to focus on. And I'd love to come back to you and your colleagues to see if we can build that in a bit better than we have it at the moment.
Fantastic. So I'm conscious we've got 2 minutes left, Mark. So I'm going to move us from the Q&A to the where to from here for everyone. So I'm going to move thanks across to the next slide. Thanks. So the next steps for consumers. I mentioned the survey, the links here, and we will be sending this out to you, this webinar, so you'll be able to access it there as well. Encourage everyone to participate in the consultation survey. And then if you're interested and you haven't already said you'd like to come to the Consumer Roundtable, do let us know. There's a way for you to express your interest on our website there. So they're the 2 next things we do. As you can hear, thanks, we can move the slide along. As you can hear, Mark has been incredibly generous both with his time and his responses today. So I'd love it if you thank him in the usual way. Those of you that know how to use their emojis or the chat or the Q&A to say thank you, that would be really terrific. There you go. See, they're floating up now for you. Oh, we've been a party for you there, Mark. How about that? On a Tuesday morning, you've got a party happening here.
Wonderful.
So thank you so much to you and your team for providing this opportunity. I suspect that many people will look at this and it will give them much more clarity about why they should care about the work that you're doing, because for some it might feel like it's more a clinical thing than a consumer thing, but we believe, as you do, that this is integral, that we have a loud voice from consumers about what we need our healthcare system and indeed our practitioners to deliver for us. So thank you once again for your time, and we look forward to the next steps.
Great. Thank you, Elizabeth, and thanks for making this great opportunity available, and we're really looking forward to the forum on the 26th. Thanks again.
All right. Thanks, everyone. Go well. Have a great day.